So without further ado, I'm going to introduce Dr. Chochinov. It's the third time that I have done it today. And I think each time I do it, it's more of a pleasure because we get to know him a little better. And he has been so wonderful to bring here. He has been so flexible. We've worked him so very hard, and we're indeed grateful that he is here. He's a distinguished professor of psychiatry at the University of Manitoba and a senior scientist at the Cancer Care Manitoba Research Institute. His research offers new insights on palliative care and person-centered care. He has more than 350 career publications and 30,000 citations of those around the world. And he has looked at many topics, such as depression, quality of life, suicide, vulnerability, spirituality, and existential distress towards end of life. I've said that word 4 times and I haven't got it right yet. You know, I've had the pleasure of talking to Dr. Chochinov numerous times as we have planned for this event, and we've talked about what he might talk about and his areas of expertise, and he reminded me often during those conversations, because I would be talking from the perspective of the Hospice Palliative Care Association, that his areas of expertise extend way beyond hospice palliative care, that this is about person-centered care and compassionate care that really is an overarching theme for all areas of care, whether it be in a formal setting or for those of us who are caregivers at home. Dr. Chochinov has also led a program of research on dignity in the healthcare setting, which includes a whole new area of study called dignity therapy. He is co-editor of the Handbook of Psychiatry and Palliative Medicine by Oxford University Press, and his latest book, which is entitled Dignity and Care, The Human Side of Medicine, also published by Oxford University, will be released in November. He has been the recipient of numerous honors and awards, including the Canadian Medical Association's highest recognition, the FNG Star Award. He is a recipient of the Order of Manitoba and is an officer in the Order of Canada. In 2020, he was inducted into the Canadian Medical Hall of Fame. Please help me give a warm Cape Breton welcome to Dr. Harvey Max Chochinov.
Here we go again. Here we go again, absolutely. So welcome, everyone. I'm here, you're here, the technology is here and working. What could go wrong, right? So by a show of hands, how many people are here tonight listening to me for the first time? Oh, thank God. So I can tell a joke and it might not have been heard, so thank you for being here. How many people are hearing me for the second time? And by a show of hands, for how many people is this your third round? Oh my God, they're stalking me. The only good news is for the people who are here 3 times, if I have a massive coronary and they have to take me off the stage, any one of them will be capable of coming up here and delivering the remainder of my remarks. So let me also offer a reflection on introductions, because I've had some wonderful introductions. Last week, well, of course, the introduction today was beautiful. Last week, I was at a meeting in Banff, and the person introduced me as, I couldn't make this stuff up, introduced me as the Moses of palliative care. And I thought that's really kind, but there's nothing that I'm going to say that needs to be etched in stone. So I thought, though, okay, despite all of that, I'm calm. This is going to be fine, sort of temper expectations. And then President Dingwall introduces me as not just one of the greatest minds in Canada, but one of the greatest minds in the world. And I thought, it's kind, but it's not helpful, David. It's just not helpful. So I'm going to be focusing the majority of my time on something that I have coined intensive caring, and the importance of showing up. I talked about this a little bit in my talk this afternoon, but this evening I thought I would just spend some time focusing on that particular area. But to begin, I am hoping to show this short video. Thank you. Okay, so why did I decide to do this? Well, three reasons. The first thing is I had to show something new for the stalkers. I mean, they had to see something that they hadn't seen before. So at least you can walk away saying, okay, it was worth the price of admission. The second reason, I knew that this talk was happening after dinner, and I thought everybody might be feeling a bit drowsy, and you're no longer drowsy. You're on the edge of your seat. And the third, more important or serious reason is to remind all of us that the moment we're born, our lives take flight. And the moment we're in flight, we are destined, one day or the other, we are destined eventually to land. And that is true for all of us and without exception. Let me now segue to Dame Cicely Saunders. Dame Saunders, as many in this room have heard me say several times, Dame Saunders was the founder of the modern hospice movement. What's interesting is she trained as a social worker, she trained as a nurse, and she trained as a physician, which in some ways, I mean, it's an important lesson just looking at the trajectory of her career, because it says, if you are going to provide care that is meaningfully attentive, you need to understand people from those various different vantage points. The other thing that I've told some of the folks earlier on, and I'll tell the newbies here, when I went to visit St. Christopher's Hospice, I was a speaker there many years ago. I came in the room, my colleague Irene Higginson, a wonderful palliative care researcher, snapped this photo. And the reason Dame Saunders and I are looking so happy is that this is her liquor cabinet. And these are empty sherry glasses. She didn't want to talk about my research. I'm not even sure she knew about my research, but at 10 in the morning, she said, would you care for a sherry? I thought, well, I'm going to be giving a lecture in a few minutes, but if Dame Saunders wants a sherry, we're going to drink sherry. And you'll notice those glasses are empty. The other place that I was able to go through after my most recent talk at St. Christopher's was to give grand rounds at Oxford, and the gentleman I'm standing with is Robert Twycross. Robert Twycross is a pioneer in palliative care. His name may not be as well known to some of you as Dame Cicely's, but he is the person who conducted the first trials of opioids in patients with chronic pain. Now, the point I want to make is I did all of these talks in the UK, and the reception from the British audience, like they raised the bar on what an appreciative audience looks like. I'm just saying. Okay. So, turning to a more serious note, and this is really the beginning of my thinking about what I have now coined intensive caring. So Dame Cicely famously said, you matter because you are you, and you matter to the end of your life, and we will do all that we can not only to help you die peacefully, but to help you live peacefully, until you die. That is kind of a central tenet of palliative care. I mean, worldwide, the philosophy of palliative care, it usually harkens back to these words. But the one thing that Dame Cicely didn't necessarily say a lot about was, so how do you provide care to people who feel that they no longer matter? And that got me thinking, well, is there a way of being able to provide care when people are suffering, when they're feeling hopeless or worthless, or like a patient I spoke about this afternoon who had felt like breathing has become redundant. What is the point of continuing to live? And when I think about that, this image painted by Robert Pope, the Nova Scotia artist, always comes to mind because I see an image of somebody who's kind of precariously teetering on the water surface, and what threatens to pull that person under, and what are the forces that sustain that individual. When I was thinking about intensive caring, I thought, well, if you are in dire straits physically, if you're really unwell, we have an intensive care unit, to attend to all of your physical needs. But what happens if the nature of your suffering is more existential, spiritual, psychological? That's where we need a way of being attentive that could be effective. So I then began writing this article, which was published just a couple of years ago in the Journal of Clinical Oncology, called Intensive Caring, Reminding Patients They Matter. And what I'd like to spend the short time that we have together is kind of walking you through what I think of as, the 5 key steps or the 5 key features of intensive caring. So the first one is non-abandonment. Now, the dynamics of abandonment in medicine have to do with feeling helpless. I remember years ago, and this goes back many moons, when I was a medical student, and doing my residency as well, because this certainly happened then. And that is that you would do rounds with your staff person. You would go around to see everyone on the ward, and if there was time, you might then go and visit a person whose ailment, was beyond cure. Or the staff person would just sort of dismiss the rest of the team, send us home, and he or she would go and visit this person, which is exactly the opposite approach that's required. I mean, the person whose ailment is beyond cure, somebody who does need to be attended to, requires both care. I refer to the differentiation between health care, which is what health organizations essentially are, healthcare administrations, healthcare institutions, versus health caring. And there is a vast difference between those. So the dynamics of non-abandonment have to do with feeling, I'm going to withdraw from a situation where I feel I just don't have anything to offer. My black bag is empty. I've got no tools that are effective. And no one wants to feel helpless. And if there are things that aren't readily curable, you're likely to find yourself saying to your trainees, well, let's go see everybody else. And if there may be time at the end of the day, perhaps we'll drop by and say hello, or not. So abandonment or non-abandonment tenet really says, get over yourself. Show up. Yes, it's hard, but show up. And showing up gives you the opportunity to make a quality connection, to provide ongoing support. And Dame Cicely, interestingly enough, said, suffering is only intolerable when no one cares. When I hear myself sounding like I'm pontificating, I like to go back to the data, because you might say, well, showing up, that doesn't sound very scientific. I mean, he's got all these research publications, so where's the science in that? Well, I mean, this is not a study that I did, but there's a woman named Kelly Trevino, an American oncologist, and she studied young patients with advanced malignancies. The thing that was most predictive of suicidality in this cohort was not psychiatric medication. It was the connection and the solidity of the connection between the patient and the healthcare provider. So in case anyone is thinking, well, showing up, is that really that powerful? Well, it seems to make the difference between wanting to go on and not wanting to go on. Okay, so that's the first element of intensive caring. The second element, taking an interest in the person. I mean, if you're going to show up, you need to do something. So taking an interest in who this person is. And that's going to help you establish, an empathic, respectful connection. And also, it gives you a chance to affirm, and that's not a word that's used much in medicine, but I think it's an important one, to provide affirmation. By virtue of my being here and our connection, I can affirm the fact that, you're an important person to me. I'm interested in what you have to say. So affirming who they are, who they were, who they wanted to be. We, in our research, have spent years looking at, well, are there different ways of kind of putting this personhood, if you will, on the clinical radar? And we've developed various different approaches. Dignity therapy, which was referred to in the introduction, is a psychotherapeutic or psychological intervention that was designed at the time specifically for patients nearing end of life. Over the last 2 decades, it's kind of grown legs and walked into different areas in medicine, areas where people are feeling that personhood is under assault. Essentially, what dignity therapy does with a trained therapist, and over the years we've trained hundreds, if not thousands, of people around the world, and there are programs worldwide, to facilitate a conversation with somebody that allows them to kind of create their legacy, to tell their story, to say, these are the things that matter, or these are the memories that I want preserved. These are the things I would want, those who survived me to kind of remember or think about. This is the guidance I might provide. Those conversations are recorded, they're transcribed, there's an editing protocol. So at the end of the day, we're able to then return that to the patient. So in essence, they have something that indeed will even be transcendent of death. It is something that can live beyond them. And that is one of the things that people who are near the end of life sometimes grapple with is, will my life have, will there be a ripple effect? Did it mean something because I was here? Dignity therapy gives people a chance to tell their story. And at this point, there are, over 100 studies on dignity therapy in different contexts, and at least a dozen systematic reviews on dignity therapy showing how it can, enhance well-being, spiritual well-being, quality of life, sense of dignity, depression, anxiety, and even demoralization. So to make it more tangible, here's a story of a gentleman, and again, I use these paintings by Robert Pope to remind me of the things that I want to talk about. This is a story of a gentleman who was actually the first person that I ever did dignity therapy with. So he had colorectal cancer. He was being treated on the palliative care program in the community. The nurses had told the treating physician that the patient had gone on a quote-unquote hunger strike, wasn't eating, and he decided to bring him into the hospital. And this physician consulted me. And I think the fantasy was, Harvey will see him, he'll sprinkle Prozac on him, the staff, everybody will feel better. And, we'll all, kind of move on from that. So I came in to see him. He was in his mid to late 60s, as I recall. I was very young then, so I thought he was an older gentleman. Now I say he was a very youthful, very youthful gentleman. And one of the first things he said when I walked in the room is, if we were in a European country where I could press that button now, I would. And of course, you know what he was talking about. If I were in a place where there was an option that I could just kind of check out, count me in, sign me up. So I thought, okay, well, I've got my work cut out for me. And I began to do a, kind of a comprehensive, basic, psychiatric evaluation. And it became clear this man was not clinically depressed. There wasn't any psychiatric disorder per se. And the only thing that Prozac would do is probably make him a little agitated and be of no help whatsoever. So I said, well, we're just playing with this new approach that we call dignity therapy. And I described it to him. I said, if you like, I'm prepared to come back here, in a day or two. And there's an ethos of immediacy. If you're important, then your words are important and you're not wanting to be put on hold. So I will come back as soon as you're ready, and I will guide you through a conversation, helping you to reflect on things that you might want to talk about, things that you might feel are important to be said. And he listened, and mercifully, and it certainly changed my life, he said, well, that sounds really interesting. I think I'd like to do that. And so I started to pack things up, and we made a a date for me to return. And as I was leaving the room, I turned to him and I said, so by the way, if you could press that button now, would you? And he looked at me with a sort of sheepish smile and said, well, no, I'd actually like to do this first. And I remember, to this day, I ran downstairs to the oncology clinic. Paul Danick was the name of the oncologist. I said, Paul, it's like palliative care penicillin. Like, can you believe this? And Paul said, Harvey, you need to do the studies. I mean, it's an N of one. You need to do this. And of course, that took up the next decade of my life. So I returned maybe a couple of days later, recorder in hand. At that time, we had a tape recorder. I guess, does anybody know what a tape recorder is still? Yes. Okay. It spun around. Set it up, but he was looking particularly ill, and I said, "Look, no pressure. If you need to delay for another," he said, "No, you're here, so let's see how this goes." What happened is something I've seen happen on many instances, which is he kind of sat up in bed, and he just started to engage in the questions, and he started to talk about his family, the immigration from the old country, coming to Canada. The birth of his children, the tragic death of one of his children, the incredible accomplishments of his other children, and even some reflections on how he would want his wife, who will soon be bereft, to kind of live out her days. It was wonderful. So we went off and we got that transcribed and put it through the editing process. So you sort of basically transform this conversation, this dialogue, into this kind of pristine narrative. It reads as if somebody had written this at a time when they could have, when they were in their best state of mind. By the time I came back to his bedside, and maybe 5 days or so had passed, he was too weak to actually take it from my hand. But his wife was sitting at the bedside, and she knew all about it, and she took the document from my hand, and she said, "This will be a blessing to our family." So that was the first instance of dignity therapy. I'm just going to take a drink for a moment. Like I said, at this point, there are studies on dignity therapy seem to be a growth industry. This is just meant to be a collage of the systematic reviews that I could find at the time that I put together the slide. Okay, again, we're dealing with the second tenet of intensive caring, knowing the person. We've created something based on work that we've done with patients near end of life called the Patient Dignity Inventory. It consists of 25 items. Each of them are just rated from, 1, not a problem, 5, a big problem. It takes a little more than minutes for people to just say, okay, what's a problem? And they can kind of tap into, what the source of their anguish is. And the interesting thing about the Patient Dignity Inventory, or the PDI, is that it covers not only psychological issues, emotional issues, but even existential issues. For example, number 11 here, feeling like I'm no longer the person I once was. I mean, as I'll be telling you more about in a moment, we have discovered that is a profound existential issue. Feeling like this just isn't me. And again, I think I said earlier today, in any palliative care ward, it's rare that, a half a day will go by and somebody hasn't asked you about pain, bowel movements. But you have to wait a long time till somebody says, well, let's talk about how are you feeling about you? And, not feeling like you used to be. This turns out to be a profound and fundamentally important issue. Now, the thing about the PDI is that in some ways it's sort of metaphorically like a new microscope or telescope. It lets you see things that you previously couldn't see. So we've now done studies, and it's now being used in studies, in various different places around the world when people want to measure dignity-related distress. So we have applied the PDI in palliative care populations, and what do we find? Well, here you see the prevalence of each of the issues that are delineated on the PDI. And, yes, a lot of people struggle with not being able to carry out usual routines or symptoms. The essence of palliative care really grew up around symptom management. Not being able to carry out important roles, really important stuff, followed by feeling like I'm no longer who I was. So it's not only so says I, but the evidence says this is important stuff. This is something that bothers patients, and we need to be mindful of. Not feeling like who you are is something that I've been writing about lately and using language like fractured personhood. It's about a feeling of brokenness. And this is one of those instances where I have found that what you learn in palliative care research seems to apply across kind of the entirety of life. So recently, we published a paper that was conducted not in palliative care, but an inpatient psychiatric facility, asking patients who were struggling with some psychiatric ailment to rate their dignity-related distress on this instrument and looking at issues that they were struggling with. What did we find? We found there were strong correlations, strong connections between sense of dignity and suicidality and depression. In other words, if you're going to try and understand why does somebody no longer want to be here, understanding the dynamics of dignity seems to be a really important area. And again, I think it's an area that's kind of ripe for research. And this is actually the paper that was in the Canadian Journal of Psychiatry. The simplest, straightforward way that we have tried to introduce in terms of putting personhood, again, the second tenet, know who this person is asking the question, we've coined it the patient dignity question, what should I know about you as a person to help me take the best care of you that I can? And the protocol is basically to go to the bedside. It's not my father calling, Digging, is it? No, okay. Just before we started, my dad called. I said, I'm about to give a talk. He says, okay, have a good talk. And I said, okay, good. After that, I was prepared to go. And it calmed me down after David's remarks, to be quite frank. You hear from your father, he says, Harvey, you're going to be okay. Don't worry about what David said. You don't have to be the biggest brain on the planet to still give a good talk. So the question the way we do it is we go to the bedside and we say, well, look, we know lots about what's happening with you medically, but we sure don't know a whole lot about who you are as a person. So what would I need to know about you as a person, as a human being, to kind of have a better sense of you, and so I can take the best care of you? It's meant to be the beginning of a brief conversation, 5 or 10 minutes. We then go off and we summarize it into 2-3 paragraphs, because no one's going to read more than that. Come back to the bedside and say to the patient, we're going to read it, we let them edit it, and litmus test. Do we have your permission to place this on your chart? We've studied several hundred, and now in the literature, there are several thousands of people who've been documented who have done the PDQ. In no instance have I ever heard somebody say, you know, that information that you just got about me that describes exactly how I would like people to see me? I don't want you putting that on my chart. It just doesn't happen. And by the way, it can be done by either the patient or the families. Families are very good at saying, they may not be able to speak for themselves, but do you want to know who you're looking after? Here's who you're looking after. And I'll give you an example in a moment, actually. We did a study of the PDQ in intensive care units during COVID. So exactly the same protocol, except the intensivist will call up the family at home, say, we've got some folks here who would like to do a study about personhood. Are you willing to talk with them? Once we had consent, we called the family at home, and we conducted the protocol as I've described. So this is the paragraph of a woman. Her mother was in intensive care, not because of COVID, but she was on a ventilator. And it reads as follows. Terry wants the healthcare team to know that her mother is not any ordinary patient, but is a very special woman. Quote, since my mother was admitted, I've been struggling to find a way to share my mother's story with the staff. But my heart is so happy that this PDQ will now allow me to do so. I hope the staff read my mother's story and appreciate the life she lived. And in very fine print, essentially the 30 or 35 people that we've done this with have all marked on an ordinal scale, with 5 being the top rating. And basically you can see all of these numbers are as close to 5 as possible, meaning it was important, I want it on the chart, I think this could affect my loved one's health care. Doing this was an emotionally meaningful experience. And I can tell you, having done some of these, you'd have people on the other end of the phone who were just gobsmacked. They could not believe you were calling them to find out about who they are. I mean, you don't want to know their blood type or their medical, you want to know who they are. It was extraordinary. And also said that this is something, almost without fail, this is something that should be offered by other families whose loved ones are in intensive care. Again, evidence from our studies to say, it's accurate. That patients say they think it's going to change the way they are cared for. It's important things for their healthcare provider to know about. And healthcare providers who read these, 90% of the time say, I didn't know that. It tells them something that wasn't on their radar. And it increases sense of connectedness, respect, and empathy. And at this point, it's been translated into multiple languages. There's about, I think, 20 summarized on this particular graphic. Okay, 2 down, 3 to go. The next tenet of intensive caring I've called a dignity-affirming tone or therapeutic presence. In other words, you need to know that when you walk in the room, that your presence, your demeanor, in and of itself is important. In and of itself is a form of intervention. It's like Dame Cicely said, you show up. I mean, what you do or what you say is sometimes less important. In fact, sometimes not saying anything actually is more effective than saying something, but being there. Now, these elements of intensive caring come from a study that we did years ago looking at the optimal elements of communication. It was done in a group of psycho-oncology professionals across the country. And you can see it includes things like empathy, non-judgmental, being authentic, trustworthy, being fully present. This is something that really takes a certain degree of mindfulness, because all of us are kind of invariably distracted. This is never far away. And so to be able to set that aside, to be able to come into somebody's room for whatever time you have and be fully present. I talked about a study earlier today that showed that a randomized trial of sitting versus standing. When people sit down and are fully present, the perception of the person who's on the receiving end is a massive distortion in the amount of time they were there, and massively, overwhelmingly heightened satisfaction compared to the same interaction had they actually stood at the bedside. So your presence is an important therapeutic tool. I talked about this earlier on today, and that is, thinking about your presence. And again, this is based on data, but metaphorically, patients are looking for this reflection in the eye of the healthcare provider to affirm their sense of dignity or personhood. If the only thing that people see, metaphorically, when you walk in the room is a problem checklist, a differential diagnosis, a treatment plan, then they feel like, I am my tumor, I am my wonky blood results, and that's the problem of patienthood eclipsing personhood. This graphic is by a Dutch graphic artist, M.C. Escher, and it's a self-portrait. And the reason I include it is because I see affirmation. The reflection you see is of this debonair-looking man in his apartment surrounded by his books and his belongings. What you're seeing is Escher. If you only saw the illness, the differential, the treatment plan, that's where people suffer. And there was a famous internist in the United States, Eric Cassell. If you haven't heard of him or read him and you're interested in suffering, he has a classic article called The Nature of Suffering. It was in the New England Journal of Medicine. And he talks about the fact that suffering is experienced by whole persons, and it's when they feel that personhood is under assault or under threat of disintegration. Wherever the threat comes from, it could be physical, psychological, spiritual, existential. So we are in a position to provide this affirming gaze so that personhood feels like it somehow can remain intact. This next one is perhaps a particularly nuanced one. I mean, if you're interested, you may want to go to the Journal of Clinical Oncology and read the article. But what I call this is knowing what is possible. Hopelessness is contagious. If patients feel hopeless, oftentimes their families will feel hopeless. And even healthcare providers can start to feel hopeless, like, what is the point? We need to be mindful as healthcare providers of what indeed is possible. And if anybody who's worked in palliative care discovers that there are lots of things that happen in those times to the very end. Some of them, and Hollywood doesn't happen a lot, but it does happen where I have seen I remember one instance where there was a man who, he and his wife did not have a good relationship. And near the end of her life, they were kind of estranged, and it was hard. But we were able to finally get them to the point where at least he could come into the room. And it's not like there was this grand reconciliation, but they were able to acknowledge that things were hard, but we did some things right. And, they had 3 children, and we could kind of be grateful for the fact that we did that. I can tell you, having met with this gentleman after the fact, it has been a transformative kind of experience, because without that, think about all of the lingering, doubt and guilt and remorse. There's so many things that can happen. When my mother was dying, goes back 2 years ago, the last thing when my older daughter, so her first granddaughter, walked into the room, I started to exit the room to give them space. But what I remember my daughter saying to my mother was thanking her for making her life better, her entire life better. Now, did it make a difference to my mother? Well, to the extent that she was able to kind of take that in. But for my daughter, yes, to know that that's something that's not left undone. So these are the kinds of things we need to be mindful of if we're going to think about this idea of knowing what is possible. The next one, we're doing very well. The next and final one is what I call therapeutic humility. And this is, as I've described in the article, being able to tolerate clinical ambiguity, honoring the patient's expertise, trusting the process, and avoiding the need to fix or having to fix in order to feel justified having a role to play. And this is just a line that I excerpted from the article. Therapeutic humility sees notions of fixing yield to commitment to understanding the nature of the patient's suffering while creating a safe space to bear witness, to validate, and to comfort always. So the reason that I say this with so much enthusiasm, besides the fact I'm trying to meet David's bar, the reason I say it with so much enthusiasm is that it seems to me a really interesting kind of paradigm shift. And what I mean by that is the traditional medical paradigm is, and it's really the paradigm that probably attracted most of us into medicine, is you can examine someone, you can make a diagnosis, and you can fix it. And I think, as I was saying in my previous talk, when I briefly spoke about this, it works sometimes. And when it does, boy, it feels fantastic. You look at the chest x-ray, there's the problem. You give the antibiotic, you come back after the course is finished and say, that was pretty good. That feels wonderful. But all of us in this room have lived long enough, we've been in the biz long enough to know that there are lots of things that don't lend themselves well to this paradigm. There are things that are beyond the grasp of being curable. And either we say, well, that's no longer in my lane, that's not part of medicine, we dismiss ourselves from that, which means we have a very limited practice, and aren't available for people in ways that are profoundly important and can't attend to their suffering. Or we shift paradigm, which is to embrace these notions, these tenets of intensive caring. So the idea of examination really needs to yield to who is this person? The idea of diagnosis really yields to, well, what is the nature of their suffering? And the idea of fixing really kind of morphs into providing comfort, always being with, not abandoning. The article ends, as I'm almost about to end, by saying this: it's been more than 50 years since Dame Cicely shared the wisdom informing this clinical approach, and decades later, when medicine's reach to fix exceeds its grasp, the time to consider the role of intensive caring is now. So, just before I go, or take questions, that is, I think, and we have time for questions. Oh, we're doing very well. 35 minutes is what I've got on my clock, and perfect. So 2 years ago, I was asked to deliver the speech for the white coat ceremony by the dean. The dean's a man wearing the very fancy orange tie. He wears different color ties, but they're all bow ties. He loves that kind of look. And I'll leave you with just 2 things that I think kind of summarize and echo some of the main sentiments that I try to convey in today's talk. So one of the things that I said, and if those of you who are interested in hearing the full speech, there's the QR code and you can go online and hear it at your leisure. So I guess the two things that I said to them, and I'll leave you with, is in healthcare, aspire to be more than human body mechanics. Aspire to be healers. And the last thing that I said to them, and that I'll leave with you, is patients won't care what you know until they know that you care. So with that, I'm happy to take questions. Thanks so much.
Does anyone have any questions?
I do. That was a beautiful talk. Thank you so much. One of the areas that I'm passionate about in my career as a nurse has always been around people who have substance use disorder and are marginalized by it. They're street involved, they may be homeless. This idea of the dignity index, is there any application for that in that particular demographic?
I love the question, and I love the idea. As I said, over time, what seems to be happening, the dignity work emerged out of palliative care experience and research. But what's happened over the last couple of decades is it's finding its ways into other areas of medicine. I mean, I've even seen some of the citations of this work in rehab medicine and cardiology, nephrology. It's kind of unexpected. It also has found its way into psychiatry. I've seen a trial of dignity therapy in patients who are in psychiatric facilities or being treated by psychiatrists. And that recent study that I showed you that indicated that people who are experiencing some psychiatric ailment also seem to have an association between their sense of dignity and suicidality. Getting back to your specific question, what happens when you, like substance abuse or being homeless or being marginalized is, personhood is truly under assault, and you are seeing oftentimes through a lens that has a bias that says, are you worthwhile looking after? Are you somebody we should be attending to? Are you So there's this whole internal dialogue that sometimes that kind of creates kind of an iatrogenic suffering. So what I would say is, great idea. You look very young. I am much older. And, it's a kind of thing where, you need to kind of gather together people to say, there's something to this. Why don't we start to look, and you can make it simple. You don't have to start with something large. If you're working in a clinic, even start with something like the patient dignity question or the patient dignity inventory, either of them, and just start using it in your practice. Use it with half a dozen, even 20 patients. At that point, and document, and then you'll have a sense, okay, isn't this interesting? We seem to be finding out something about these patients that we didn't know. And I would suspect what you'll find out is those issues around sense of self, feeling intact, feeling a burden, I think those are likely going to be off the charts. And when they are, you can say, well, what can we do about this? At least we have evidence that says, here's the problem. Now we need some resources maybe to try and address that, like the patient dignity question. And that question, by the way, certainly in many palliative care circles, is becoming kind of routine. It's hard to provide, quality, palliative care is about whole person-centered care. You can't do whole person-centered care in the absence of knowing the person. So it's a good place to start. And I think substance abuse would be a fabulous cohort of people to begin implementing it in. You are very young, right? Younger than me.
Another question.
What did you mean on one of those slides, modeling how to die?
Great. So the question is, what does it mean, modeling how to die? So I can best illustrate that with an example, and I may have given it to that I gave this example to one of the groups up, but don't tell me who it is, because otherwise I'll know you're actually sitting here bored. So, oh, he's not going to tell that story again, is he? So my PhD student is doing a study in which she's interviewing people who have been approved for MAID. And she's going to either their homes or the bedside to find out, so we want to find out what led you down this path. And one gentleman that she saw not so long ago, we said, so why are you doing this? Like, how did you come to this decision? And what he said is that I'm not going to die the way my grandmother did. She had a terrible death, and so I'm going to take a different path. As it turned out, as I told the group today, when I asked when she died, it was 30 years ago. So for 30 years, he had carried around this template of what dying looks like. So the point I'm making, and the point of modeling how to die, it is that whether the person in that palliative care bed likes it or not, they are creating a memory for all of the people who bear witness in terms of what dying looks like. And that memory is going to shape, maybe sometimes even distort, or kind of affirm what normal dying can look like, and is going to carry forward until it's their own time. So that's what I mean by modeling how to die. I remember one psychiatrist who actually told me about a consultation, and he had come into the room of a patient who was really despondent and felt there's no point, and this psychiatrist was a bit brusque with him, and he said, listen, you're still teaching your children stuff. They're watching you. They want to know how this is done. So that is, sort of maybe a more crass illustration of what we mean by modeling to die. But it's remembering that people bear witness, and those witnesses are shaped and influenced until their final days.
We have one more question.
Yes. I saw someone scratch their head at the back, but I don't think was asking a question. I've also said, at least on one occasion, that I'm a psychiatrist, so I'm comfortable with silences. 1/3 of the audience laughed. 2/3 said, I think you said that before. Hello.
Once again, I really enjoyed your speech, and the connection Julie just made to people with substance use disorder. As you were speaking, I couldn't help but think about the slow death of dementia and the connections between the two. They're very good at understanding and asking those questions of who is this person as an individual. But what they can really learn from your work is the dignity therapy. What about all these other pieces that we need to be thinking about now? And how do we work with our people who are losing themselves slowly?
Yeah.
And
And even when cognition begins to disintegrate, dignity remains salient. It remains salient until the very end. Even beyond that, I mean, the way that we treat somebody who has died has to be with a certain kind of dignity and reverence. Why? Because they were that person. But getting back to the living, there actually have been studies using dignity therapy in people with cognitive decline. Sometimes it has been with a kind of a family member who has kind of been a co-creator of that document, and sometimes it's been the family member who's doing it by proxy. I mean, I'm now seeing papers, and I'm not doing all this work. I sort of feel like you plant some seeds and you stand back for a couple of decades and you see what grows. I'm now seeing people writing about this whole idea of dignity therapy by proxy, whether or not it's an elderly person who doesn't have a voice, or a young child who may never have a voice or have a congenital issue that is going to cause a foreshortened life expectancy, and others can stand in their stead and say, this is who this person is. And you might say, well, what difference does that make to the person? I'd say, well, I mean, it's sometimes hard to tap into that, although if you can shift the tone of care, even shifting the tone of care can cause emotional regulation. But for the family, I mean, families suffer when they feel that their loved one is seen as a generic, body simply to be, toileted and cleaned, and not the human being that they really are. And the other thing that we found is that if healthcare providers can become aware of some of these storylines, it changes the way you see someone. Like the story of the woman I said today, or the one this afternoon. I had an example of a woman who said, I'm a residential school survivor. My family moved 82 times. I don't trust people who wear white coats. I said, well, how in the world do you provide care to that person in the absence of knowing that? It would be like my trying to get from here to the parking lot with all the lights out. It might be possible, but it would look really ugly. And why do that? Why not turn the lights on and provide dignity-conserving care?
Well, folks, it's quite warm in this room. So
Have you noticed? I thought it was just me. Thank you. Thank you.
So it is warm in here, and this is no lengthy closing. Just to say we are really glad to have had this event. We've never brought in a speaker like Dr. Chochinov before. It's kind of our goal to work together as a community to learn more. We've learned a huge amount today, over 3 presentations, and we thank him for sharing our wealth. I hope we've shared some things with him too, and I guess in thanking you all for being here, I like to think that one of the special parts about being in this community is that we're working hard to build connections with each other and to build a caring and compassionate community. And we're learning all the technical parts, and we're learning to get better on many places, but it's nice to be pulling together and learning as we go, because sort of this end-of-life care piece is part of our compassionate community. So thank you all for coming, thank you for supporting us, and thank you again for Dr. Chochinov. We've worked him really hard, so we have to let him go home. So safe travel home, everyone. Excuse me, sorry.
Thank you for indulging us. I just have a very brief comment or two, and I just want to say it because it means so much for us to be able to be here tonight and to celebrate so much with our wonderful partners, Cape Breton University, and celebrate that this is probably one of the first lectures from an external lecturer for the new class of 2029. And we have a medical student who's here with us today, and we have a family medicine resident here with us today, and this is the future of medicine. So aren't we lucky we have this accomplishment? And it's my great pleasure and privilege to thank Dr. Chochinov. He may not be Moses, but he certainly is as wise as Moses. And what I mean by that is, I don't know if you know Dr. Chochinov, but you certainly have influenced palliative care, not only across Canada, but globally. Your research, your insight, your wisdom, your caring, and your humility has made a huge impact. And anytime I've heard you, I've come away knowing something more than I knew before. I also want to say that your contributions have advanced palliative care, not only for the patients and the families, but for those of us who are clinicians who work with these patients and families. It's made a huge difference for us, and it reminded me of one thing that I learned a long time ago and I carry with me, and that's that statement that to cure sometimes, to relieve often, but to comfort always. And for me, when I think about those hard times when maybe it would be easier to walk away, being present makes all the difference in the world. So I wanted to thank you, and I wanted to, especially one more thing, to point out that Dr. Dave, I always call you Dr. Dave, because your wise counsel is very appreciated, Dave. President David Dingwall has been a tireless advocate for palliative care, a friend and a supporter. And I remember it was in 2019 that I sat down with you as part of a leadership project, I think you'll remember that, Dave, to talk about distributed medical education. And I believe Frank Van Schaik also was very generous with his time. He was at the Nova Scotia Health Authority. And the partners I had in the project were doctors from Halifax, and they said, "You'll never get those two guys to sit down with you." And I said, "I'll give it a try." Well, we had some wonderful conversation, and I can't believe that now, 6 years later, we have the first class enrolled in the Faculty of Medicine, Dalhousie Cape Breton Medical Campus. And I once again just want to give congratulations and say what a wonderful community we have and how lucky we are. So safe home, everyone, and take care.